大家好啊！多謝大家收睇我哋今集呢，就係香港兒童醫院模擬培訓中心 Child Sim 嘅一集。我係今日嘅 Moderator Jeff Wong，係呢間醫院嘅 PICU 醫生。我哋今日好榮幸呢，請到 Dr. Vivian Yuen， 佢係我哋麻醉科嘅部門主管，嚟同我哋講一個好嚴重但係又好危險嘅 topic，就係 Malignant Hyperthermia in Children。咁麻煩你啊，袁醫生，唔該晒你。
多謝晒 Jeff 嘅介紹。我哋今日嘅 topic 咧係 Malignant Hyperthermia in Children。咁我哋即係其實呢個 topics 都喺我哋麻醉裏邊咧成日都有出現㗎啦。咁但係咧其實呢個係我哋成日都講嘅 topics 啦，可能會，但係真係會發生嘅時候咧就真係好少嘅。咁咧，我有一樣嘢要 declare 啦。首先就係咧其實即係少到其實touchwood 我係自己冇預見過嘅，所以好多嘢咧，我哋都係喺可能書本啊或者一啲 publication 裏邊去認識啦。咁啊加埋係一啲嘅 training 啦。咁究竟呢個 disease 有幾 rare 咧？咁佢最初 report 嘅時候咧，就係1960年第一個嘅 case report。咁喺呢個 case report 咧，就係一個叫做Mike Damburoff 嘅人啦。咁佢就 report 咗一個 case， 呢個 case 咧係一個21歲嘅後生仔。咁佢有一個 compound fracture of tibia and fibula。咁佢就 so that he needs general anesthesia for fixation of his fracture。咁佢一聽到佢要 general anesthesia，佢就好驚啊！嗰陣時佢就話：我屋企咧裏邊已經有10個人因為 general anesthesia 死咗㗎啦。咁咧嗰個麻醉科醫生就唔緊要，我哋而家有隻新藥，因為咧以前咧都係用 ether 嘅，而家呢個藥咧係 Halothin， 應該冇問題㗎啦咁樣啦。咁點知咧呢個病人咧喺個anesthesia 裏邊都係好 eventful 啦，即係佢係突然間好 tachycardia、hypercarbia， 最後都係要resuscitation。 好彩佢就係佢冇死到嘅，但係都係一個好 eventful 嘅 anesthesia 啦。佢又發高燒啦。咁 in the end 咧，佢哋就覺得係我哋要即係去了解究竟係咩嘢嘅一件事啦。So that 佢哋就去研究究竟係咩嘢導致到呢個病人同埋佢之前嘅 relative 咧都係 suffer from 一個好 eventful 嘅 anesthesia 啦。咁Mike Damburoff 係一個 pioneer in malignant hyperthermia， 佢哋後邊就發現咗其實呢個係一個 hereditary disease。咁而呢個人咧除咗係一個 pioneer in malignant hyperthermia 同埋係一個 medical academic 之外咧，另外一樣嘢咧就佢係一個佢係個 founder of nuclear de-armament， 同 medical 冇關係嘅。咁佢就有一本書 publish 咗叫做 Australia and Nuclear War。咁呢個即係一個side track 咗啦。But since his investigation and research in MH, we know a lot more about this disease subsequently。咁喺我頭先都講啦，其實 MH 係一個好 rare 嘅disease， 好 rare 嘅 occurrence 啦。咁我哋點樣去認識到呢個嘅病咧？其實都係靠好多集埋嘅 cases 啦。咁喺美國咧就有一個叫做Malignant Hyperthermia 嘅 registry。咁我哋就係靠呢一個 registry， 其實咧都係去再了解多啲呢啲嘅 case 嘅。咁呢個叫做 MHAUS 啦。咁而呢個 registry 其實或者 MHAUS 咧，佢哋都 hold 一個 MH hotline 嘅。呢個 hotline 咧，佢哋係 operate on 7/24。咁即係其實係一班好熱心嘅 anesthesia consultant 咧，佢哋就即係 take turn 去 take course 嘅。咁係即係 24/7 啦。咁係 for management of 一啲 emergency scenario or 一啲 preparatory phase of suspected MH， 佢哋都會 take call 嘅。咁佢哋因為即係有一班咁嘅人隨時 take call 啦，咁佢哋就大概咧通常都有1 to 2 cases per week，and then overall 咧佢哋係會有1 to 2 mortality per year。咁呢個係如果有人 call 佢哋咁佢哋就會即係捉到呢啲 case 啦。咁overall mortality may be about 2%， 但係 mortality is much high in countries where dantrolene is not readily available 啦。
但呢個 registry 就主要係 focus 翻喺美國嘅，
係啦，係一個美國嘅
但係就唔會受其他
registry
國家嗰啲嘅即係可以 register。
係你打唔到電話俾佢嘅。
咁我哋香港就冇呢啲咁嘅 provision。
喺香港係未有嘅，咁同埋喺東南亞國家我都未知道有嘅，係啦。係啦，咁所以其實究竟有幾多人係 susceptible to malignant hyperthermia 咧？我諗呢個都係一個 myth 嚟嘅。咁但係而家我哋即係以前啦，in the old days we say it's very very rare, maybe 1 in 200,000 people would be susceptible。但係咧而家因為有 genetic testing 咧，其實可能我哋會係揾到1 in 2,000 to 3,000，咁所以 it's not that rare。咁呢個係即係 whether you have the gene and make you susceptible to malignant hyperthermia。But even though if you are susceptible, doesn't mean you will manifest。咁個 incidence 咧，咁可能即係有一個CJA 即係 Canadian Journal of Anesthesia publish 咧，就大概1 in 15 to 1 in 75,000 anesthesia 啦。咁因為佢咁 rare，其實都好難知道嗰個 exact incidence 啦。咁 it is reported to be more common in children than adults, most commonly a condition of children and young adults 啦。2/3 of the MH susceptible individuals will have an MH event during their first anesthetic。但係咧有一啲人咧其實係可能有一啲 uneventful 嘅 anesthesia，and then on their subsequent anesthesia they present with MH。So 另外一樣嘢咧就係 almost all MH patients do not show physiological changes without anesthesia。So that means in another words, anyone who appear healthy may be susceptible。所以你唔知道佢幾時會發生咯。咁我哋知道有一啲 diseases 咧係 associated with malignant hyperthermia 嘅。咁呢啲都係即係呢度有3個 disease 啦，我哋係知道啦，叫做 Evans myopathy 或者 King-Danborough syndrome or central core disease。而呢啲都係一啲好 rare 嘅 myopathy 啦。咁再有其他嘅 myopathy， 好似 Duchenne muscular dystrophy 或者 Becker 咧，其實佢哋呢啲嘅病人唔係 exactly MH susceptible，但係咧佢哋就係會對啲succinylcholine啦or maybe volatile agent 會有一啲reaction， 所以佢哋會 develop rhabdomyolysis，但係嗰個 mechanism 係唔同嘅。咁咧，仲有一啲 patient 咧，係如果佢哋有 history of recurrent stroke or rhabdomyolysis，maybe they are at increased risk because 喺USA 佢哋而家即係知道呢樣嘢越嚟越多啦。咁佢哋發覺咧 ，50% of the soldier suffering from stroke demonstrate MH mutation。咁我哋頭先都講過，如果你有 MH mutation 咧，又唔代表你真係會 manifest 嗰個 MH 啦，因為呢個係一個hereditary disease with variable penetrance。咁so in the end我哋 normally we won't ask whether a patient had a history of heat stroke or exercise-induced rhabdomyolysis, but if you have a patient with such history, you may manage them as MH susceptible。咁pathophysiology 啦，我哋頭先講過，佢都係一個 pharmacogenetic disease， so you have to have a abnormal or mutation so that when you are exposed to triggering agent like volatile anesthetic or depolarizing muscle relaxant, then you may manifest malignant hyperthermia. It is its inheritance is autosomal dominance with variable penetrance. Genetic mutation occur in the rhinal receptor. So 到而家我諗我哋大概知道有3至4個 gene 啦，但係又有好多嘅variant 啦，可能會 make you susceptible to malignant hyperthermia 啦。咁個原因就係個 mutation 令到個 calcium release become uncontrolled when you are exposed to triggering agent, which produce a hypermetabolic state within the skeletal muscle. 咁all things happen with the uncontrolled release of calcium intracellularly. 而呢一個 calcium release 咧就會影響咗你個 metabolism 啦，which leads to CO2 production and hyperthermia. On the other hand, it also increase oxygen consumption 啦，exhaust 咗你嘅aerobic pathway, so it leads to anaerobic metabolism and lactic acidosis. It also 最大嘅問題就係佢會 lead to muscle contraction or contracture, muscle rigidity, and muscle lysis. In the end, it leads to release of myoglobin and acute renal failure and DIC. And the most important part is it leads to hyperkalemia and cardiac arrest. So hyperkalemia is the culprit or is the enemy that we have to deal with in malignant hyperthermia. So dantrolene is the only specific drug to manage malignant hyperthermia. It is introduced in 1975. It is a ryanodine receptor antagonist that inhibits pathologically increased calcium release from the sarcoplasmic reticulum. 我哋即係 ryanodine receptor, there are 3 different ryanodine receptor, and dantrolene works on RYR1 and RYR3. So where the RYR2 receptor is present in our cardiac muscle, so that's why administration of dantrolene would not affect your cardiac contractility, and it should not cause hypotension. So with the use of dantrolene, the mortality rate actually dropped from 70 to 80% to about 5%. Up to now, I think in China, dantrolene is still not available because it is a non-registered drug. So this is the mortality rate of MH in China, up to 7-80%. Diagnosis. Of course, clinical presentation, when you have someone who exposed to the triggering agent and presented with hypermetabolic state, including hypercarbia, tachycardia, and fever. Or the gold standard to diagnose MH is the contracture test, where we use caffeine and halotene to stimulate skeletal muscle. It is a physiological test. That means we cannot send specimen to laboratory for tests. We have to have live, fresh specimen sent to the lab to test. So 因為喺香港我哋而家就未做到呢個 contracture test 啦。如果我哋有一啲 MH susceptible patient, they actually have to personally go overseas to have the test done. So the closest overseas center for MH contracture tests is Japan, I think. Otherwise, you can go to Australia, or there are only 4 to 5 centers in the whole United States. This is the gold standard, so it is a very sensitive test. And then more commonly done nowadays is genetic test, because it can be done anywhere, and the tests continue to improve, and we are identifying more genes associated with malignant hyperthermia that include RYR1, CACN1S, or STAC3. I think these are the genes we test locally in Hong Kong too, because I have just asked Dr. Li Yuen about this, and this is the genes she will test if we present to her for someone we want to test whether this is a MH susceptible patient. However, this test is still of low sensitivity. So if you have a positive test, then we definitely treat the patient as MH susceptible. But if you have a negative test, it doesn't mean that you are not susceptible. So you still have to either go for the contracture test, or we treat you as a susceptible individual. So we learn a lot from the MH registry, and this is the first report of the MH registry, cover I think about 20 years data, and over this period there were just under 300 episodes reported to the registry, and about 100 of them were certain 170 of them were highly likely MH. So 6.5% of these patients had a positive family history. A lot of these are young patient, right? Some of these patients had remarkable general anesthesia history. And in this cohort, there were 4 deaths. So the first and only sign, 38% of this cohort had hypercarbia as the first sign or even the only sign. And a lot of the patients presented with sinus tachycardia. About half of these patients had muscle rigidity. Only 1/5 had masseter muscle spasm. 8.2 had high temperature as the first sign. 3.9% had high temperature as the initial sign. But a lot of these patients had temperature abnormalities. So the first presenting sign could be muscle masseter spasm, but it occurs in 1/5 of the patients. So the most common sign will be hypercarbia followed by tachycardia, and then temperature rise, so hyperthermia. And almost all of these patients would develop respiratory acidosis. So in this cohort, the management, the time between first sign and first dantrolene was about 30 minutes. And 22 patients received no dantrolene. 2 reported complications was resulted from dantrolene administration, and then the time to discontinuation of triggering agent from onset of symptom was about 10 minutes. So about half of the patient received sodium bicarbonate. So, about 1/3 of the patient had complication as a result of MH or its treatment, and the likelihood of any complication increased about 3 times per 2 degrees Celsius increase in temperature. So, or 1.6 times for delay in administration of dantrolene. So it reveals even better here. For longer time it takes to administer the first dose of dantrolene, the higher the complication rate resulted from MH. And And then this is another newer report. So this is a cohort over 5 years from the registry. So overall, there were 84 cases reported to the registry. And among this cohort, there were 8 deaths. And 5 of these patients were healthy patients pre-op, and they all underwent quite low risk or intermediate risk surgery, and the median age were about 30 years old. And only about 10% of these patients were discovered to have positive family history. So this is an interesting graph. You see the sign with cross are the patient who die in this cohort, right? So you can tell that more patients die when the temperature rise about 38.5 degrees Celsius. And the color indicate what kind of temperature monitor they have. So you can see that when they have core temperature monitor around here, or the green dots, the chance of dying from MH is lower comparing to a patient who had no temperature monitor or only skin temperature monitor. So this is a very informative graph. Another table, it just shows that the mortality actually is associated with the type of temperature monitor you use intraoperatively. And also it is associated with the induction to time of dantrolene administration. So the longer it takes for the dantrolene to be administered, the higher the chance of mortality. So the take-home message, and also there is some change of guideline in United States as well as from Hong Kong College of Anesthesiology is to prevent MH death. Clinicians should monitor core temperature intraoperatively whenever the patient undergoes general anesthesia for more than 30 minutes. So this is another or the only registry we have so far in the United States on children. So these are patients under 18 years old. And this registry includes about 250 patients. Most of the patients are in the age range of 2 to 12 and 13 to 18 years old. And the mortality rate among the three age groups were not different, but you can see the presentation of MH is actually quite different. You can see that in the older age group, they have more incidence of hypercarbia, the typical presentation of malignant hyperthermia. Hypercarbia, tachycardia, they have higher peak CK level. So they exhibit hypermetabolic state. They might have more skeletal muscle mass. And for the younger age group, because they might not have the skeletal muscle mass, they actually present with metabolic complication with a lower pH and anaerobic metabolism and hypoperfusion. So how do we manage malignant hyperthermia? It is very simple on paper. Remove the triggering agents. So stop what is causing the problem, give dantrolene, the only reversal we have for now. And then every other thing is supportive. So control your hyperkalemia, cooling, maintain hydration, maintain hemodynamic stability, monitor and treat your other electrolyte abnormality, and treat acidosis with mannitol and sodium bicarbonate. So sodium bicarbonate will help to correct the acidosis as well as hyperkalemia. And of course, when we are treating someone with hypermetabolic state, we have to be wary whether this is other cause of hypermetabolic state. So we have to think about differential as usual all the time. Whether this could be thyroid toxicosis, pheochromocytoma, neural lab malignant syndrome, serotonin syndrome, or intoxication or iatrogenic condition. Same as, I think this is more common in intensive care setting. When you have someone with high fever, you think of sepsis first, right? But then we also think of other causes like MH, neural lab malignant syndrome, serotonin, or intoxication, etc. So it is very simple on paper, but when you drill or when you manage MH or when you manage something that can evolve and happen so quickly, it is not uncommon that we become scared, right? And also we will, it become quite messy. And also to err is human. This is very, I think we all know this, to err is human. And that's why in management of such crisis, we will use things like cognitive aids or other means like to drill. So this is what we have in our department. Because this is like a simple cognitive aid. We always print it and place it everywhere in our department in the drawer. So for easy access, so you can take it out whenever you have crisis. And if you have a crisis or you have a patient in front of you and you suspect MH, then you can just take this out and read over what to do. So just in case you miss out something or you become blank and you don't know what to do or you don't remember the dantrolene dose, then you can quickly to get something to refer to. Or if you go into trouble like hyperkalemia, then you can flip over and just read what do I do apart from giving calcium? What else do I do? Or I should prepare to do CPR, hyperventilate, give calcium chloride, etc. So this is some easy and quick guide. And for management of MH, as recommended by the MHANZ, this is Australia and New Zealand Society for Malignant Hyperthermia, they actually recommend using cognitive aids. So apart from a quick guide with the cognitive aid we have in the department, we also make all these aids so that when you have an MH, the first thing we do is call for help, right? And then the second thing we do is to get the MH box. MH box, then we will open and we have all the dantrolene, all the drugs we need to resuscitate, but we also take out the MH cards. So the first task of the anesthetist when we receive this box is to distribute the MH card. So each one involved in the case will get their card. So I don't have to tell you what to do. You just read the card and you will do all the tasks, list out the card on the card and do what you're supposed to be doing, because it is a very messy and complicated situation. And then drill is very important. We had Jackie and Simulation Center helping us to do our first MH drill just recently in November last year. And after this drill, we actually identify a few problems. Marina from our department helped to organize this drill, and we have everyone participated in the drill. And first problem was mixing dantrolene. We don't even have a proper working bench for mixing dantrolene, and we just have figured out it is actually very difficult to mix the drug in a short period of time under stress and when we are not familiar with the drug. So we redo the cognitive aids for mixing dantrolene, and we have to do more training and so on. And the second problem we identified was we actually had the cognitive aids lying everywhere. So you read it once and then you put it somewhere and then you lost the card. You don't know where to find and you don't know what to do. So actually from the recommendation of MHANZ, they recommend hanging the card on your neck.
Oh, okay.
So initially we thought, oh, it's okay, we don't need to hang it on the neck, as long as you have a card, you should be fine. But then after this drill, we think, oh, this is a very wise recommendation. So we redo the card, and now we can hang it on the neck, and you can read it when you are actually working on the crisis. And third, we also have to tidy up our resuscitation card or equipment and defibrillator and so on, so that hopefully in the real situation of resuscitation or MH management, we are not so messy. So this is so we learn a lot from this simulation with the help from Simulation Center. And last thing I want to talk about is ryanodesmol for malignant hyperthermia. So after this, I have to rethink. Actually, I present to DTC previously to purchase this drug for management of MH, but it was declined because first, this is not a registered drug as yet, as dantrolene is also not registered in Hong Kong. But the advantage of ryanodesmol is a non-suspension formulation of dantrolene. So basically, apart from it is being more expensive, but it is a very small vial for a much larger dose. It is much easier to be mixed. So with 5 ml of water, you have 250 milligram of dantrolene, whereas our conventional or normal preparation of dantrolene, you need about 12.5 or 10 vials to be equivalent to one small vial. So it is a lot easier in a messy situation, critical situation where timely administration of dantrolene makes a difference. So, of course, this is a very expensive drug. That's why we were declined when we applied to DTC to purchase this drug for management of malignant hyperthermia. But after this drill and with the endorsement from our COC, I will present to DTC again. Hopefully, I will gain support. And I think this is all from me. And take-home message is anyone may be susceptible because they can be healthy and they can come for simple surgery. It is a pharmacogenetic disease. Only susceptible individual will develop the disease when exposed to the triggering agents. Conventionally, we know volatile agent and succinylcholine, but nowadays we suspect, some patients might be triggered by exercise or heat or stress. So as I think with time we may know more about the disease. And the malignant is hyperkalemia. So abort and make aggressive treatment of hyperkalemia and aggressive cooling is the ultimate management, I think.
Okay. 哇！好多謝袁醫生嘅講學啦，我相信咁多位觀眾同埋我都即係學咗好多嘢啦。咁我有兩個問題想問一問嘅。第一個問題咧，其實就關於嗰個頭先你有張 slide 講到啦，就話越早探測到呢個病就越早醫就越好啦，嗰個 outcome 又會好啲啦。咁我第一個問題就係想問下，譬如而家喺手術室，你哋嘅探測就係話即係會點做啦？咁如果譬如以我理解就話可能會擺個譬如 rectal probe 啊嗰啲啦。咁但係如果個手術係做嗰個位置附近嘅手術，你擺唔到，咁又有咩替代品咧？
我哋應該90% 時間都係用 core temperature 啦，咁會係用nasopharyngeal temperature probe 或 oral pharyngeal temperature probe， 即係 esophageal probe， 咁都係 core temperature 嚟嘅。咁有啲係做口嘅手術啦，咁我哋就會用 either rectal temperature 啦。如果 rectum 係擺唔到嘅，冇辦法就要 skin 咯。
即係去到最後就用 skin 代替咁樣。
咁就會比較少啦，即係我哋大部分都係 core temperature 嘅。即係我諗喺 OT 大部分嘅 OT 都係嘅。
OK， 好，多謝你，呢個我又學咗一樣新嘅嘢。我第二個問題咧係就係想講緊嗰啲病人嘅處理嘅，因為你都知啦，兒童醫院咧，我哋其實都會有好多rare disease 啦，譬如你講嗰啲 myopathy 啊，或者 central coma 嗰邊，可能真係會有呢啲病人啦。咁我想問嘅問題係，如果有一個病人佢譬如有個病史已經係曾經出現過呢種 malignant hyperthermia 喺個 OT 度。而佢不幸又要再做手術喎，咁你有冇咩預防性質嘅嘢要做咧？譬如話俾定藥佢啦，定係會點做㗎？
其實如果我哋知道或者我哋懷疑咧，就都相對簡單嘅，因為我哋可以用 trigger-free anesthesia。咁我哋首先我哋唔會用 succinylcholine 啦。其實而家即係 nowadays 都用得少嘅，即係我哋有好多non-depolarizing muscle relaxant 嘅 alternative 啦。咁另外咧就係我哋就唔用 volatile agent 咯。咁可能我哋如果係已經知道，我哋就用一個 clean 嘅麻醉機啦。因為我哋就算唔開我哋個 volatile agent， 我哋都驚有啲 residual 嘅 volatile anesthetic 留咗喺個 soda lime 啊嗰啲或者個機器裏邊啦。所以我哋係有一部 clean 嘅麻醉機，係從來都冇 volatile 嘅。咁我哋用嘅 anesthetic 咧就 IV anesthetic 咯。咁其實都係propofol 啦，或者任何 IV 嘅嘢咯。
即係原來有咁嘅準備。
係啦
OK， 真係又長咗多啲知識添，真係多謝你啊，袁醫生。咁我相信其實好多位觀眾都即係都好有可能有啲問題啦。咁我哋希望下次再有機會咧，能夠請到袁醫生再為我哋講下多啲其他關於小朋友嘅唔同嘅麻醉科嘅病症啊咁樣樣。咁喺呢度咧，我就代表香港兒童醫院模擬培訓中心咧，就好多謝袁醫生你今日嚟教我哋嘅嘢啦。咁我哋呢度咧有少少嘅禮物咧，想送俾袁醫生嘅。
唔該晒，多謝，好靚。
多謝袁醫生。